So it is a diagnostic tool, as I told you, to assess the upper airway of snorers and obstructive sleep apnea patients to produce a condition like natural sleep. And we have to understand the upper airway behavior during sleep so that we can produce a tailor-made solution for each and every patient. And during natural sleep, it is complicated and impractical to do it on a daily basis. So we are observing the movement of the palate, tongue, and all these things observed dynamically during sleep, and it is possible to have the desired outcomes. And sedation level that resembles the natural sleep is given so that we can identify the behavior of the upper airway during that time. And dice must be performed in a room with all the basic resuscitation equipment like oxygen supply, immediate intubation tools, and safety is the most important, especially when you do it in a morbidly obese patient who is not relieved of the OSA problem and you want to do it as a diagnostic test. Safety becomes the utmost important issue, so you have to be very careful in your pre-testing preparation with the all. If you anticipate a difficult airway, you must have some help to immediately intervene and safeguard the patient. And the room should be quiet and dark so that the patient is not stimulated by too much of lighting and noise in the diagnostic room. And you must have a ECG and pulse oximeter on the patient to find out whether the patient goes in for any arrhythmias because of hypoxemia or hypothermia. And saturation should be continuously monitored. And bispectral index is used to achieve a value of between 70 and 50 to indicate adequate sleep stage that has been achieved. And in a lighter sedation, if you assess the upper airway, you underestimate the obstruction. So it should be at the correct depth of anesthesia or sedation, which may produce a natural sleep-like situation. Whereas deeper sedation, the value going below 50, may produce artificial obstruction. So it is a very tricky situation that you correctly give the dosage of the drug, neither to keep the patient too light or to make him too deep. That is a very important thing that we have to practice. And children, these values may not be applicable because they don't respond correctly to that. And we must use the thinnest possible fiber endoscope. And usually for an adult, we use the 4.2 pediatric scope for this. And with the working channel, it should be able to aspirate the saliva or secretions. And ideally, these patients are asked to have a meal at least 3-4 hours before you do this testing. Okay? Not necessary that they should be in total NPO like a surgery, but they are advised to have a light meal at least 3 to 4 hours before you do this procedure so that you can avoid the chances of regurgitation and aspiration. And recording system of video and sound is easily incorporated so that you can have pictures of the various structures that we visualize using the endoscope, and that can be helpful in determining the treatment also. And it can be video recorded so that you can play that to the patient and make them understand their problem as well as potential difficulty in addressing their obstruction. And the useful feature is previous surgery do not achieve the desired outcomes. If obstruction is so severe, unnecessarily doing a palatoplasty or removing a tonsil to enlarge the size of the upper airway may not result in complete relief of this problem. And the drugs that we normally use are midazolam, propofol, mefenamic, and PIP. And it can be used alone or in combination to achieve the adequate level of sedation. And with propofol using target control PCI pumps provides better control than individually or combinedly using the other drugs. Comparing natural sleep to PCI propofol sleep has been shown to be shown that the critical closing pressures, UA muscle responsiveness, and apnea hypopnea index levels of sedation measured by BIS and sites of obstruction are equivalent to those observed during the N2 and N3 stages of natural sleep. So instead of giving intermittent bolus or unmonitored intravenous injections, PCI pump works to produce a state which mimics natural sleep very correctly. So REM sleep cannot be produced with propofol sedation, and it usually takes only about 15 to 30 minutes within the short duration. Only N2 sleep can be achieved because of the short nature of the procedure. It is during this stage that most of the events occur, unlike in the REM sleep. And dice should be considered a snapshot of what is happening during the night. So it is something like a trailer for your main picture, and it cannot provide the sequential things that happen during the entire night. Titrate the PCI pump slowly to achieve the ideal level of sedation, and pump can be programmed to 2 to 2.5 microgram per ml with an increase of 0.5 microgram every 2 minutes until the level of sedation is achieved if you are using a PCI pump. The addition of 1 to 2 milligram of metazolam at the beginning of the sedation will shorten the time to the observation window, although it may also cause an increase in sneezing, making the assessment more difficult. And dice, because it's not a painful procedure, no local anesthetic spraying of the nose is necessary, and also nasal decongestant usage like Otrivin or Nesivian is not required. And patients are usually observed in supine ubiquitous position. But if they have the habit of sleeping in the lateral position, you can get that information from the history and do the testing in the lateral decubitus position itself. And usually, once the patient goes to the sleep stage, most of the patients with OSA, they have open mouth breathing. So they open their mouth, and that produces a fall of the tongue, and that contributes to the obstruction along with the pharyngeal collapse. So if the mouth was open, tongue may be moving back, producing obstruction. So changes to the areas and pattern of obstruction can be observed by simply closing the mouth or pulling the mandible forward. So in chin lift, what do you do normally to remove the obstruction? How do you bring the mandible forward when you do a chin lift?
Angle of the mandible will lift.
You put your fingers down both the angle of the mandible and push it forward. Whereas in this S-mark maneuver, you hold it at the front. At the level of lower incisors, you hold the whole bone and teeth and pull the mandible forward. Okay. So
Yes,
the
sir.
chin lift maneuver is pushing the mandible from behind, whereas S-mark maneuver is pulling the mandible from the front. That is the major difference between the two. So this picture will tell you how to do it. You put on a glove, hold the chin and put your finger in the mouth into the lower incisor level and pull the whole mandible. And because the patient is sleeping, his jaw will be very relaxed. So it will be easy to pull the mandible forward. And then you can start doing the observation, see the palate and how it closes. And then observe the base of the tongue, epiglottis, and all these things. And most of the time it is impossible the tongue base and epiglottis, as the soft palate is also falling back to come onto the pharynx. So after observing the soft palate for 1 to 2 minutes, the stroke can be advanced downward to observe the rest of the upper airway. After observing every level, you can proceed with the maneuver. Longer observation is not useful, as the upper airway will be full of saliva due to the inhibition of deglutition by propofol. So patient will not be swallowing, so it will be full of saliva. You can ask me whether we can give anti-sialagogue like glycopyrrolate to avoid this, but usually it is not recommended because once this is a short procedure, after that when the patient wakes up, you will have a dry mouth and you cannot have anything to eat or drink and they will find it uncomfortable. So normally anti-sialagogues are not prescribed in these patients and the events may be observed as areas of vibration or shapes of collapse. For the purpose of the shapes of collapse or obstruction, the tip of the endoscope should be in the middle of the upper airway. So these are all the pictures how they will look like. This is another picture. Here it is all given how it looks like. In the examples of complete collapse observed at different areas, the picture A shows the anteroposterior velum, that is soft palate. Velum means soft palate. There is an anteroposterior collapse. And once you rotate, this is the lateral view, how it looks like. And this is the circular view of the soft palate. So it collapses like this in these three different positions. And then D is the oropharynx lateral. So once you cross and go advance below the soft palate, you go to the oropharynx. And this is the lateral view of the oropharynx. E is the base of the tongue. And you can see the base of the tongue opening like a or bends like a book. And G is the tongue base and it's concentric, and there is an anteroposterior movement of the tongue, and the lateral walls also contribute to the collapse. And H is the epiglottis. You can see this is the epiglottis. And epiglottis is a lateral view. So it looks like something has been folded. You can see that's how the whole thing behaves. So all these things will be recorded as a video or a picturized in the monitor, which you can later go through repeatedly playing through that. Now, what are the indications for doing this trick? If the patient is unable to tolerate CPAP or BiPAP, decide which treatment is best for them, you can do this. It's also performed with to understand why there is a failure of CPAP and what are all the areas we look at. The velum is soft palate, oropharyngeal walls, tongue base, and epiglottis. So you take the first letter and produce an acronym called the Vogt classification. And the configuration we have to see in the anteroposterior, lateral, and circular three positions in the degree of obstruction, and this is how the reporting is done. And the contraindications for DICE are American Society of Anesthesiologists class 4 patients or patients who are pregnant or patients who have any allergy to these drugs which we are going to use for sedation. They are all contraindicated. A high apnea hypopnea index is not a contraindication in DICE. So you can go ahead and do that. Report the level of sedation, lowest oxygen saturation, what are all the drugs used, including their dosage and delivery mode to achieve the sedation, and what are all the QA findings. That will be, of course, automatically recorded in the monitor, and you will get a CD or a pen drive to watch it later on. And what maneuvers performed during DSE. All these things have to be recorded. Okay, so that is what we have to write about DICE. This was asked once or twice in the question papers.